Hi, my name is Craig Lammert. I'm the Executive Director for the Autoimmune Hepatitis Association. I'm also a hepatologist at Indiana University. I'm really pleased to have Dr. Ermel again with us today. You may remember Dr. Ermel as a part of our COVID series last year. He agreed to sit down and have a few conversations about what's going on with the COVID pandemic, as well as a few questions that our members have had. Hey, Dr. Ermel, thanks so much for joining us today.
No problem. Thanks.
Hey, so I think part of our membership profile has come to notice what's going on in the media, and we're seeing COVID numbers go up. I thought we'd start off maybe just seeing your input as far as any predictions for the fall or winter from an infectious disease perspective and what we're seeing here at our University of Indiana.
Yeah, so I preface like any prediction is it could easily be wrong, right? And so
Sure.
When I look at the current, environment and I look at people's behavior, I would still say we're at risk of having some seasonal surges, but to the degree that we saw over the last fall and winter, I don't believe so. Just because we're at a different place than we were before, which is slowly rising vaccine rates, evolving vaccines, and then also kind of there is a bit of natural immunity that has built up within the population, which probably has some effect. So I don't see us quite being back to where we were before. I hope not, but that we can still see some seasonal spikes.
Sure. Do we anticipate that hospitalizations and death will also increase?
Yeah, so I don't think they will increase to the degree that we've seen before. So right now, as you're following kind of this like Omicron subvariant increase here in the US, when you look at hospitalization, though it's increasing, the curve doesn't look anything like what we saw back like in December, January. And then even like the deaths are kind of trailing at a much lower rate. So I hope that bodes well for future outbreaks and kind of where the virus itself is trying to go, which is not necessarily more virulent, but just more transmissible.
Great. So it seems like you've mentioned this already, a lot of the important pieces has been vaccination status. And we've, as an organization, have been very much for our immunosuppressed population to be vaccinated. At least current guidelines from our understanding is that 4 doses is still important and protective. We're getting further into the pandemic, obviously, and again, further away from our immunosuppressed patients' last dose. Are we still seeing that vaccines are protecting patients with this subvariant? And maybe beyond that, do we know the direction of vaccination in the next 6 months to a year?
Yeah, we're still seeing, we're seeing to just infection probably lower protection than we would want, but that risk of death and hospitalization is actually still significantly reduced with the vaccines. The problem when I coach my patients on the 4th dose, so in my practice, I'm talking with a lot of patients who have HIV, for example, who maybe don't fit in the same category as patients who are chronically immunosuppressed by medications. But some of them, as their HIV is recovering and things kind of do. And so when you look at like how we studied the 4th dose, it's not like in the US, we have a whole lot of data that says it's really going to work particularly well. It was looked at mostly in Israel across a national study, and it included patients who were immunosuppressed for whatever reason. So they didn't actually break it down too much outside of there might have been a transplant subpopulation, but it still was shown to be beneficial. So I think that's the point. It wasn't as effective as we wanted. You're looking at like 60 to 70% efficacy, but that was significant for hospitalization and death. So that was, I think, the big point was that it's retained efficacy. But again, we see the same decrease in antibody levels over time, and then as you move months out, you start seeing kind of that same decrease in efficacy as we did with prior doses.
And so speaking of that and leading me on to that next point is, do you think, again, now that we're having some more patients months since that last dose, do we think we'll have any further input from governing bodies in the months to come before the end of the summer about maybe a next dose of vaccine?
Yeah, I mean, I'm hoping that as we continue to surveil the disease that we'll actually have those data to be able to say that, one, they should get a 4th dose, or the 4th dose, was of so much benefit here, because I don't see personally, I don't see as the general population outside of, I mean, even for myself, like healthcare worker, really that fourth dose being as important because of just my health status. But for my immunosuppressed patients, if they're getting it like 6 months or so out from their third dose, I'm suggesting they begin thinking about the fourth dose.
I see.
And actually, I'm suggesting, if any of the mRNA vaccines that are available, like go ahead and just use those. Don't focus on getting the same vaccine. Just a fourth dose of a vaccine may be beneficial.
Gotcha. No, that's great advice. The other transition we've seen, again, over probably the past 6 months now, is the utilization of therapies for COVID-19 infection, specifically Paxlovid, but also other protection, and that would include UV as a strategy to prevent infection for those patients that were exposed. Could you maybe speak a few moments about these agents and again, see how we're using these in practice now that we're assuming they're widely available, but how are physicians and clinicians utilizing them? Are they being used effectively, and are they really that important overall, at least within the subvariant?
Right. So to start with, just like how we're using them, it's very dependent upon your health system and what access the health system. You and I work for a very large, kind of almost health conglomerate, right? Statewide, very large buying power. So we were fortunate when our Evusheld, came out, that we were one of the first places to be able to acquire it, which was also important because of our populations where we had such heavy transplant populations and other people undergoing like immunomodulatory therapy. But there were a lot of places that didn't have that much supply. But now that we have the supply, I don't know that it's being utilized to the degree that it should. It's still kind of hard to catch people up on the recommendations when they're on certain therapies. Like ones for specifically that are like B cell depleting. So people who receive something called like rituximab, particularly, and similar drugs. Within autoimmune hepatitis, I'm not sure that, those type of drugs aren't really being utilized as much. It's other types of immunosuppressants, but we still, they're not at the highest category, but they're still somewhere in that immunosuppressed category.
Yeah.
It's reduction, but the problem with this virus and this pandemic is that studies are done during a certain period of time. And as we notice with the waves, that you have the dominance of a variant, and you might get performance characteristics during that period. You say, wow, this was so effective during the period. And I think Evusheld was actually studied mostly during Delta variant, that then you compile all of the data and you say, wow, this looks amazing. And then comes along Omicron and you find out that it's not particularly effective. It's still better than zero, but was not particularly effective at that time, and we're still administering it. But it's a lack of awareness by a physician, and then sometimes supply issues within the healthcare systems. Paxlovid is, it's actually quite effective when you look at reducing hospitalization and death, and it still retains activity within Omicron. And in fact, I just right before we were getting ready to speak, I looked into some of the reported relapses that people have had. So they take it, get a lot better, and then maybe a week later they start to not feel as bad as they did when they first had it, but then they're positive again. And it's basically just the virus kind of coming back a little bit after being controlled for a period of time. And those are very rare, but they're very informative. So they can teach us a lot about the virus. And so people who've had these relapses, when they've looked at it, they didn't find that suddenly the virus was resistant to that drug. They looked in the same areas to look for mutations, other things that would make it resistant to Paxlovid, and they didn't find them. So that's encouraging. It may just be more of a physiology of the virus, or maybe we're not taking it quite long enough to get it fully under control so our immune system can actually finish up the work, because that's really what's happening. But again, Paxlovid's actually been underutilized, and it's also been a supply issue. So not every pharmacy has been able to carry it. Some supplies have been restricted, and depending on where you are, not everyone prescribes it. So I don't particularly prescribe it. I have to refer into our like COVID outpatient group, who then has control over that supply and is able to get them the drug. We're fortunate because we have that channel, but not everywhere does. I think the other thing that's held it back is Paxlovid in particular, because of its, it's two drugs. So it's the one that's specific for SARS-CoV-2, and then it's the other drug, this ritonavir, that we use basically just to boost the level of the other drug. And so that drug interacts with quite a few others. And so people who maybe are on, like, say, tacrolimus, or maybe one of our other drugs, a little more common immunosuppressant, may run into issues with those drug levels shooting up really high at tacrolimus because they're on it. And you have to weigh that balance of, well, is it really going to help my patient that much who's been vaccinated maybe 4 times, who doesn't have like the other risk factors of heart disease, diabetes, and things, versus, you know, a potential drug interaction that, even though it's a short period of time to take, it could still actually be relatively serious, considering how the drug levels can change so rapidly with a drug like tacrolimus. So it's just weighing those potential like side effects, like we do with every other drug.
Yeah. No, that's really helpful. And you've kind of spoke about this a little bit, but I'm just looking for a little bit more clarification, maybe even for clinicians and as patients talk to their doctors. You know, in the realm of AIH, we have patients that are on immunosuppression, and then we have a spectrum of liver disease, patients with really no fibrosis to patients with really severe fibrosis. As a clinician, as a hepatologist, should I be considering these therapies? And is there a line in the sand, if you will, that I really maybe need to be thinking, at least in my own healthcare system, of getting patients to these other type of therapeutics beyond their own vaccination history?
Yeah, there isn't. I mean, unfortunately, there's not a clear line just in
Yeah.
looking at the data to say that even when they looked in their subpopulations, there wasn't one group that stood out as like, you know, if you got that, they were the ones that had to have this, or they were the ones who had the most serious events. I mean, really, when you looked at the Paxlovid trials, the number of serious adverse events was extremely low. Even the theoretical risks of the drug interactions were very low, because you're only taking the drug for like 5 days. You know,
Right.
it's not like what we see with other long-term therapy, and you worry about those things. So it's unfortunately relegated to clinician judgment at that point. But if you start taking off more boxes for high risk for hospitalization, you know, you want to give it early, because that's when the benefit is seen. It is not seen late. It is seen early. And preventing that hospitalization, even if they relapse, they're still less likely to have any severe disease relative, you know, to someone who just never took it.
Right. Well, Dr. Ermel, thank you so much. I think you've shed a lot of light on these therapies, as well as the pandemic and its current state. And I just want to tell you how grateful we are from an organizational standpoint, as well as a colleague. Thank you for providing some clarity.
Oh, thank you. Thanks for having me.